in terms of transparency, I think this is a great issue, right? Sort of what you get for the premium you pay and what exposure to risk you have. Employers have been moving in this direction. I mean, Leah, is Leapfrog or anyone else that you're aware of thinking about transparency on this domain? You know, the trade-off between the value that one gets for a high deductible plan or, you know, relative to a more traditional plan?
I think that there's been a lot of attention paid to how to manage a high deductible plan, but less attention to what's the difference. I think it's happened so rapidly, I don't even think anyone's had a chance to step back and ask the question. The research is just starting to catch up. I think there's been a little bit.
Although we have a lot of research from like Pitney Bowes from 15 years ago or 20 years ago about what happened when they put in a high deductible plan and all their diabetics got worse, and then they went in and jiggered it around, and it feels like we're going to have to relive a lot of that in terms of what gets covered.
Yeah.
Well, I think some employers are trying to do some of the creative kinds of benefits packages that you mentioned, Peggy. I mean, for example, Federal Express is doing, they waive all co-pays of any sort for people with diabetes. So, and it's an example, but it's hard for them to do it. Actually, you have to kind of get around a lot of the new regulations under the Affordable Care Act in order to do it. But I do think that the issue with high deductibles is changing the market for good or bad. It is totally transforming the market. It's a train on the tracks, it's happening, and I do think actually, your analogy is exactly right. I think consumers are the bananas in between the gorillas. Absolutely, they are really out there on their own. They're managing their own care, often with their own money, and it is changing everything. And I think that will, in fact, have an impact. Some of it is going to be a good impact, but it's going to be very, very hard for people to manage it in their own lives. It's hard on families, but it is changing things.
There's also a lot of evidence that consumers have a hard time picking plans in these markets.
Yes.
There's evidence from Medicare Part D, from Medicare Advantage, and emerging evidence from the marketplaces, although we don't have a lot of information there, that consumers are confused. Some of them have never had insurance before. Many of them don't even understand the concepts that we're talking about. So when they go and they see, you know, choice of 40 plans, different premiums, different deductibles across different time periods, different kinds of providers, co-payments and so forth, it's enormously confusing. They don't know their own costs or what the costs are going to be. Studies have also shown that when you provide them with either a smart default or cost estimators that are fairly accurate, you kind of make that really easy for them to consume, and you give them some education, they do a lot better. They understand and they make better choices.
So insurance is really about assumption of risk, and Peggy mentioned earlier kind of consolidation on the provider side. We also see risk, at least if you believe kind of the popular press, risk being assumed by providers as well. So when we think about plans assuming risk or providers assuming risk, has the balance of where that risk is held changed, or is it changing?
Well, I'm not sure what's happening in the private sector with this too much, but on the Medicare ACOs, there are kind of a lot of people hanging out in the shared savings model, right? So that's really not the intention to sort of stay with no downside risk. I mean, as one of my board members says, no downside risk means no risk, right?
Right.
That's right.
What are you seeing in Medicaid? Similar story? Or?
Absolutely, absolutely. And one of the, when I talk to providers, primary care physicians or what have you, and I talk about the things that are happening and the risk models that are changing and capitation and all this stuff. Their first reaction is to kind of say, well, I don't really get that. I mean, because how can I, as the primary care doctor, be held responsible? How can I be held at risk for patient behavior that is outside of my control? I've got these four walls in my office. Somebody walks in, they present with a condition, I diagnose, I treat, I give them a plan of care, they walk out. What happens? I don't know. I can't control that. Are they taking their meds or not? Are they filling them? I can't control that. Are they engaging in risky behaviors again? I can't. But the key is, well, no, you don't influence or control that now. Well, it's because we've never actually given you a financial incentive to do so. And so what's happening in places like Arkansas, where they're building patient-centered medical homes with shared savings, is they're empowering the physician to create these teams. And so it's the physician as the quarterback, but they've got nurses, but they've got social workers, and they've got community health workers. people who can follow the individual outside of the four walls. Where do they live? Do they live in a big urban high-rise? Do they live in a shack down by the river? You can figure out how to tailor your engagement with the patient that way. And so the risk has to change, but the tools have to change as well.
If it's not team-based, it won't work.
Right.
And if you don't have the data, I mean, we've seen miraculous things happen when there's actually data provided at the point of care that says so-and-so is needing to have their diabetes care adjusted because they're out of control. You know, and it's quite possible by linking different data systems to give the practitioners the right information at the right time.
Right.
A handful of purchasers have been very interested in the ACO model and have actually started working directly with these ACOs to sort of work through some of these transition issues, because it doesn't happen overnight. Just because you say, here's the incentive on the table, everybody doesn't suddenly change their behavior. So they have been skeptical that that would happen, and they feel they were right to be skeptical because they've seen how that transition has unfolded. But I do think that it is promising, but it is promising if it's well managed by either government, if it's Medicaid or Medicare, or the private sector purchasers themselves,
And
or
we
the
need to get
plans.
payers together, because if
Right.
everybody's got a different model, Medicare here, Medicaid here, private
Yeah.
payer X, Y,
That's
and
right.
Z there, that doesn't work.
Absolutely. Yeah. Hey, Matt,